These are all complicated things, but I will simplify it by just saying that cortical stroke, depending upon the area involved, will throw the symptoms. So left frontal lobe has got left frontal dominant set of functions. If there is a cortical stroke involving that, there will be dysfunction depending upon that area. So broadly, you have four lobes, and grossly, I've told you the functions that we use. And to put it in one line, higher mental functions will be affected. Higher mental functions involve all these things. Now, you should know about homunculus when we talk about stroke. So this is the brain. There is a pink part, there is a blue part. Okay. The pink part is the somatomotor, the blue part is the somatosensory. So when I'll be talking about ACMC territories, I'll be talking about the sulci and gyri, and there I'll explain that there is a central sulcus, there is a premotor area, there is a uh, sensory area. So basically, what happens is if you take out this area from this side, medial and lateral, and look through it with the coronal section. So there is a motor representation of the brain like this. So the medial half has predominant coverage of toes and knees, that is lower limb. Then comes the trunk. And see the area which is taken care of by the hand and the face. So the area that is representing the hand and face, see the area involved. This is huge and large compared to lower limbs, which is small. And then you have an area which takes care of the neck, tongue, and the pharynx, which is the opercular region. So you just have to grossly know about the homunculus. If you know about the homunculus, the localization will again become easy for you, because there is some part of blood supply which supplies this part. There is one artery which supplies this. So ACA supplies this middle part. When ACA supplies these middle part and if ACA is blocked, what will happen? You will have a lower limb predominant weakness. MCA supplies this half. So if you have a MCA territory infarct, you will have predominantly fasciobrachial. For the time being, this homunculus is important to you for cortical stroke localization. Now what happens is they have just taken off the one half and the other half is still with you. Now what happens is, see, this is foot, toes, genitalia, leg, hip, trunk, neck, head, arm, shoulder. So this is a gray matter, okay? Now the fibers, just imagine it like this. The fibers of each one of this area will descend down. So this is a widespread area now. Okay. Fibers from foot, toes, and genitalia, fibers from so different fibers will come as if I have drawn in the figure. So imagine some 30, 40 odd fibers coming down. It's not 30, 40 exactly, but imagine it in that. So now if you have a cortical stroke means something which is affecting the brain on the cortex itself. So say for example, you have this area which is affected. So if this area is affected, what will you have clinically? You will at the max have a shoulder, arm, elbow, forearm, wrist, and hand. Or say you have this part of the cortex involved. So you will have foot, toes, and genitalia. So technically, you will have what I call as monoparesis or a differential limb weakness. Differential limb weakness, hemiparesis means one part of the body or one part of the limb is affected more. Now the next question arises, can there be hemiplegia in a cortical stroke? Now just imagine, if you want hemiplegia to occur, you want a large stroke, an area which involves all of this. Then only the patient will have hemiparesis involving both lower limb, upper limb, and probably some part of the face. Right? So, in order to have a hemiparesis involving the cortical lesion, you need to have a large stroke. And whenever you have a large stroke like this, there will be a lot of edema, there will be a lot of compromise, and your patient will not be conscious oriented. Your patient will be dull and drowsy. So, if a patient has hemiparesis, then patient will definitely have unconsciousness, stupor, or a comatose behavior because of the large stroke involvement in a cortical stroke. So whenever we talk about cortical stroke, the clues are it never produces dense hemiplegia. And now you know the reason why it never produces dense hemiplegia unless it is a large stroke. Large stroke means it involves both subcortex and the cortex. Differential limb involvement. So now we know about the differential limb involvement also, that how monoparesis or differential limb is the key to target the cortical stroke localization. Then comes focal seizures. Now we all know seizures come from the gray matter area. And if you have, say, for example, a lesion here, so a patient might throw a seizure to you and the seizure might march. It starts off from here and the irritative zone goes back. So focal seizure, higher mental functions are affected. Higher mental functions are affected depending upon the side of the involvement and the lobe preferentially affected. And there will be cortical sensory loss. The most important differentiation point when you are trying to localize the stroke is whether it is a cortical or a subcortical stroke. That's the first step because you all know the clue points when it comes to diagnosing a brainstem or cerebellum stroke. I'm quite sure about that. The major confusion happens when you are trying to delineate between a cortical and a subcortical stroke. So these are the key points that help you distinguish between the two. Cortical, I told you higher mental functions will be affected. Now, depending upon the lobe involved, it can be aphasia, alexia, agraphia, acalculia, heavy neglect, visuospatial disorientation, memory impairment, or behavior change. This does not mean that cortical stroke will have all these clinical signs depending upon the region, right? So, for example, if you have a patient who is aphasic, unless the cortex is involved, you will not have aphasia. I'm not talking about the rare things. I'm not talking about the unusual neurological things. There are lots and lots of areas which by subcortex, even by cerebellum can produce aphasia, but they're not going into those kind of details. Basic funda is if you have a HMF dysfunction, if you have a differential weakness, a focal motor weakness, face arm more than leg or leg more than face arm, then the possibility of cortical stroke is more compared to a patient where face, arm, and leg weakness is equal. Here you're going to think of a subcortical stroke. Then if you have cortical sensory loss like agraphesthesia, astereognosia, if you have focal sensory loss, cortical stroke is more likely. Hemisensory loss, subcortical stroke is more likely. Cranial nerve finding, subcortical stroke. So this subcortex here means subcortex here involves everything. Also involves the brainstem. So cranial nerve cerebellar findings are definitely subcortical. And again, all these above mentioned things, they are general guidelines. There are lots of exceptions. For example, lateral geniculate nucleus, although it is a subcortical, it may still result in a disturbance of visual functioning, which mimics a disorder that is the optic radiation pathway dysfunction and occipital cortex dysfunction. So these are all general guidelines that we have to follow. And trust me, if you follow it in a general way, things become more and more easy. Now comes the subcortical part. Now, the first question is what all structures are involved? What is exactly subcortex? So, subcortical structures, there are group of diverse neural formations. They are deep within the brain, and they include diencephalon, pituitary gland, limbic structures, and the basal. Now, when I say diencephalon, again, diencephalon is the posterior part of the forebrain. It is found deep within the cerebrum and it consists of thalamus, epithalamus, subthalamus, hypothalamus, all the thalamus, thalamus, epi, sub, and hypo. So this is how a subcortical diencephalon looks like, along with the pituitary gland. Then I told you that the limbic circuitry is also in the subcortical area. Now, what is the limbic circuitry? Limbic circuitry involves cingulate gyrus, parahippocampal gyrus, medial orbitofrontal, temporal pole, deep structures involve hippocampal, amygdala, olfactory, plus the diencephalon and basal ganglia itself. And don't worry, I'm still going to make it easier for you. So components of diencephalon that we already talked about, the thalami, anterior, the thalamus, hypothalamus, epithalamus, subthalamus. Plus we have corpus callosum and we have components in the cerebrum like cingulate, gyrus, parahippocampal, and the hippocampal gyrus and the amygdala. And then comes the most confusing part, the basal ganglia. Now, the basal ganglia again is made up of five pairs of nuclei: caudate, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. Now, from here, I'm going to take you to a journey of understanding the subcortical stroke. See, you have caudate nucleus, which is the nuclei is also called as the caudate nuclei. You have a lentiform nucleus, which is a lens-shaped nucleus, which has putamen plus globus pallidus. You have a claustrum, which is the claustrum. You have a corpus striatum, which is caudate nucleus plus lentiform nucleus. You have a neostriatum, which is caudate nucleus plus putamen, and you have an amygdaloid body. So now we are going to go a little bit into the subcortex. See, this was all cortical area. Okay. Now, basal ganglia, this is the caudate nucleus. This lens shaped here is the lentiform nucleus. See, it is a lens shaped nucleus, in which the upper part, the green one, is formed by the putamen, and this part is formed by globus pallidus. Globus pallidus again is subdivided into external part and more deeper internal. So, this is the lentiform nucleus. Lentiform nucleus has putamen plus globus pallidus. This putamen, along with this caudate nucleus, forms the striate. Lateral to this is the claustrum. Lateral to claustrum is the extreme capsule. And here is the internal capsule coming. So, internal capsule is nothing but a collection of white fibers. So, as I told you earlier, we have some, I showed you and I made you imagine some 50, 60 fibers coming from the cortex, which are going to come down as a unit, as a bundle, which are tightly enclosed. That bundle is going to cross from here in a V shaped or a boomerang shaped area. So it's going to come here and go from here. That is called as the internal capsule. So this is what we talked about when we were talking about the cortical area. Now, one more confusing term comes up, which is called as centrum semiovale and corona radiata. So just understand it like this. When the fibers are in the cortical area, they're called as cortical fibers. When they start to descend down, so initial part that they form is called as corona radiata. And as they go more deep, they become more tight, they become more enclosed. Once they become more enclosed, they are called as the internal capsule. So this is how they were fanned out in the beginning. Then they tried to become enclosed. Then they became a tight bundle. The tight bundle, like a boomerang, went on, and this boomerang of white fiber is called as the internal capsule. So this is how the cortical fibers were coming. They went off like this and this. Now, initially, when we talked about the cortical stroke, we said that if there is a stroke like this, it will just involve the shoulder, elbow, and wrist. If there is a stroke here, it will just involve the knee, ankle, and foot. Imagine a small stroke here at this area, a very small, tiny stroke. What will happen? It will have dense hemiplegia. Why dense hemiplegia? Because the fibers are densely converging and going via this internal capsule. So even the small infarct in the internal capsule can lead to a hemiplegia. All these fibers will be gone, from toes to shoulder to wrist to finger to thumb to probably facial also. All these fibers will be affected. In fact, these are just the corticospinal tract I'm talking about. From this fiber tract, there are corticopontine fibers also going. There are corticobulbar fibers also projecting. So you will have lots and lots of other things with the small stroke. But what about the higher mental functions? This all this area is perfectly functioning well. So no higher mental function problem. Will there be a seizure? No. Cortex is far more behind where the lesion is. How about the GCS? Again, everything is well equipped, well functioning. Only the motor weakness, motor sensory weakness, or probably a seventh cranial nerve involvement will be there. So if you have a patient who is lying on the bed with a 0 by 5 power and is completely conscious oriented and talking to you, the probability that he has a deep stroke, a subcortical stroke is high. If a patient has a 3 by 5 power or a 4 by 5 power who is completely conscious, you can think of coronary radiata infarct. That is the infarct is happening somewhere more uh, anterior to the more superficial to this deep vein. Whereas if you have a 1 by 5 or a 0 by 5 power with a normal ventilation, you will think about internal. So you can now further subclassify a subcortical stroke into whether it is a subcortical stroke at the level of coronary radiata or a subcortical stroke at the level of internal. So you can ask questions in between if you are not following. This is just a picture because every time we talk about all these things, we get confused at how this is functioning. So imagine the brain. Okay, this is how a brain is, right? And these are the fibers coming from the cortex. I told you when the fibers they start accumulating, initially they are called as central semiovale, then corona radiata, and finally internal. And this is how an internal capsule looks like. So internal capsule has an anterior limb, internal capsule has a posterior limb. Can you repeat differentiation between coronary radiata? Now see, don't try to mug up anything. I'll again go back and try to explain you how a coronary radiata infarct and yeah. So from this figure only I'll explain. See, this is the cortical fibers. Okay. Say for example, you have 50 cortical fibers, which are representing your leg, arm, face, mouth areas like this. So five fibers from leg, five from arms, five from face. Like this, you have 50 fibers. And those 50 fibers are widespread distributed in the cortex. I think this is a better figure to explain. Yeah. So they are widespread distributed. Now, if there is a cortical stroke, what will happen? If you have this much of an area involved, you will just have 10 fibers. That means even if you have a good amount of stroke, your presentation in terms of weakness will be probably monoparesis or a differential limb. And these fibers they try to accumulate, they try to go down and accumulate. Now, if there is a lesion somewhere here, same exact amount of lesion but happening here. So what will happen rather than 10, there will be 20 fibers that will be involved. So your presenting patient will come to you with say, okay, I have weakness 3 by 5 power, but my consciousness level is maintained. I don't have any kind of higher mental functional deficit because everything is happening at a subcortical compared to internal capsule where the same amount, the same lesion will lead to destruction of 45 fibers. So you will have a dense hemiplegia because everything is very densely covered. Now comes the tricky part. So although I promised that I'm not going to go into the details of arterial supply and I'm going to cover up arterial selection when we'll be discussing about the syndrome, but no discussion can about internal capsule should end without discussing the blood supply of internal capsule because internal capsule is a very prominent and an important area. It is dense. Imagine all the fibers, all the functioning fibers are accumulating there. So if something is special, everybody wants to come and say hello to that special person. And when I say everybody, all the arterial supply are going to come and say hello to internal capsule. So internal capsule again has different parts. So I told you boomerang. Boomerang is the internal capsule. So it has an anterior limb, then it has a genu, and it has a posterior limb. So this is the anterior limb. The place where it takes a turn is called the genu, and it has a posterior limb. Right. So anterior limb is supplied by the anterior cerebral artery, a branch of anterior cerebral artery which is called as the recurrent artery of Hebner, and the middle cerebral artery. The genu is supplied by the anterior cerebral artery, the middle cerebral artery, and few direct branches from the internal carotid. Posterior limb is supplied by striate branches of the middle cerebral artery and the anterior choroidal artery. And you have sublentiform part and retrolentiform part, which is supplied by the PC and choroidal, posterior choroidal artery. Now, PC and anterior choroidal. So this is confusing, right? Again, whenever things are confusing, we try to simplify them. So this is a good example of how you should remember a internal capsule blood supply. So internal capsule blood supply, I divide it into two halves. This is the anterior half and this is the posterior half. Now see, anterior limb, genu, posterior limb. Anterior limb, genu, posterior limb. Upper half or the anterior half is supplied by the striate branches of MCA. MCA. Okay. So whole of the internal capsule, dorsal half, upper half, anterior half is supplied by the MCA. Now coming to the posterior half, the ventral half. So when it comes to the posterior half, anterior limb is supplied by anterior. Okay, anterior limb is supplied by an anterior cerebral artery branch, which is called as recurrent artery of Hebner. Genu is something which is in between. And genu is something which is supplied by direct branches of ICA. Genu means genius, and ICA would like to directly come and meet the genius person. So anterior limb, because it is anterior, the anterior cerebral artery supplies it with the branch called as recurrent artery of Hebner. Genu, which is a genius, and ICA wants to directly come and say hello to the genius along with PCOM. Posterior limb, posterior half is supplied by anterior choroidal artery, and the retrolentiform part is also supplied by the anterior choroidal artery. So this diagram is rather a good simplified version of this diagram. So now whatever I have explained, I'm going to read it out to you. Subcortical strokes affect areas of the brain that chiefly consist of tract of nerve axons leading to and from the cortex. The higher functions are typically spared, and motor or sensory involvement typically manifests as complete involvement of one side of the body, that is pure motor or pure sensory or motor sensory hemiparesis, rather than more discrete lesions, which were characteristics of the homunculus that we read about in the. Right, so we talked about the cortex and the subcortical structures. Now, when I talk about the subcortical structure, I told you we can now further classify subcortical at the level of corona radiata. Corona radiata was nothing but the initial assembly of the fibers which were descending. So the subcortical lesions involve more fibers than the cortical lesions of equal size. If, say, for example, the lesion is that of an equal size, the subcortical lesion involves more fibers. Always try to remember our example of 50 fibers. So if you have 50 fibers, in the cortical stroke, 5 fibers will be involved. In the subcortex at the level of corona radiata, 10 fibers will be involved. If you go more down at internal capsule, 40 fibers will be. So patient might present to you with monoplegia or some hemiplegia at corona radiata, but there will be absence of cortical signs. Cortical signs like focal seizures, higher mental function disorders, which includes acalculia, agraphia, aphasia, and all those things. Coming to subcortical at the level of internal capsule, very easy to differentiate. Fibers are densely packed. A small lesion may produce a complete hemiplegia on the opposite side, and obviously the cortical signs will be absent here as well. So we talked about subcortical at the level of coronary data. We talked about subcortical at the level of internal capsule. Now, when I say internal capsule, I talk about everything. Internal capsule is nothing but it is passing through the basal ganglia structures. So I'm not going to go in detail of the basal ganglia structures infarct and what happens when they're infarct. We're going to talk about them when we're going to talk about the syndrome infarct. Subcortical level, I want you to tell at the level of thalamus also. So what is technically happening at the level of thalamus? We all know that the sensory fibers, they relay at thalamus. So if you have an infarct in the thalamus, there will be a contralateral hemisensory loss. Hemiplegic patient with aphasia, where to localize? I'll tell you. So contralateral hemisensory loss associated with agonizing or burning pain is called as Dejerine-Rossi syndrome that you commonly read about. You will read about it in Harrison as well. But thalamus is not that simple and easy. So thalamus, I think if you guys are interested, I don't know how important it is at the MD level, but at DM level, it is extremely important. Thalamus itself is a class. So thalamus, you should not forget about Dejerine-Rossi syndrome. You should never forget about that thalamus is the relay center and all the sensory system come and relay there. So a stroke there will lead to a hemisensory loss followed by an agonizing burning pain. This is called as Dejerine-Rossi syndrome. But thalamus is not that simple. I'm just giving you an example how complicated a thalamus can be. We can make it simpler by understanding, but thalamus has lots and lots of nucleus, lots and lots of connections because everything which is going to and fro is going via the thalamus. But this yellow part, the lateral part, the red part is the medial part, and this blue part is the anterior part. So let's just, for the time being, learn that there are three parts: the lateral part, the medial part, and the anterior part. Lateral part is further subdivided into ventral, lateral posterior dorsal, and pulvinar. So let's not get into the details. Just understand this thing that the major chunk. So when we talk about the major chunk of thalamus, this yellow part is the major chunk of thalamus. The major chunk of thalamus, the lateral and the ventral group, they had somatosensory output to the post-central gyrus or to the association area of the cortex. That is the reason why thalamic stroke, usually we always think about sensory deficits. But having said that, you guys should know that there is an anterior group of nuclei, which is a part of limbic system. And thalamus plays a role of memory and emotion as well. There is a posterior group which relays the visual signals to the occipital lobe and the auditory signal to the temporal lobe. So patient might present to you with these symptoms as well in the thalamic infarct. Now coming to the brainstem localization. I don't think any of you will have doubts about a brainstem localization. You have a clear-cut crossed hemiplegia and you have cranial nerve involvement here. And what all cranial nerves are involved? So we know that there are multiple cranial nerves which are situated in different part of the brainstem. And depending upon the cranial nerve that is involved, you can always localize what type of brainstem or where exactly is the lesion in the brainstem. So this is, I think this is the right way to learn about the cranial nerve nuclei that are in the brainstem. So the mnemonic is simple: 3, 4, 5, 6, 7, 8, 9, 10, 11. Midbrain, pons, and medulla. So midbrain has 3 and 4. But if you will see this, I think you should make a photograph of this diagram. See, there is a somatic, branchial, visceral, motor. And similarly, there is a visceral, somatic, and special sensory. This figure tells you not just the cranial nerve nuclei, but where exactly, what exactly is placed. The somatic third nerve nuclei is here in the midbrain, lying medially. The visceral is lying little laterally. So third and fourth are in the midbrain. So if you have a patient with crossed hemiplegia and third nerve involvement, fourth nerve involvement, you can at least localize that the patient has an involvement of brainstem specifically, or you can precisely go and say midbrain. Don't worry, I'm going to talk in great depths about midbrain syndromes, Weber, Claudian, all those things, Benedict's. But the fundamentals has to be clear first. So first step is you have to localize cortex, subcortex, where in subcortex, then comes the brainstem, where in brainstem, and then we'll go ahead. So 3, 4 in midbrain, 5, 6, 7, 8 nuclei in the pons, 9, 10, 11, 12 in the middle. But we all know that the fifth nucleus is fanned out and has its extension going above to the midbrain and below to the cervical spine. So this diagram is going to be of prime importance whenever I'm going to cover up brainstem strokes. And this is just a tabular version of the diagram that we saw in the last slide. So if you don't want to take brain into the account as a photo and make it a photogenic memory, you can read the same thing via this table. But rather than learning its 3, 4, 5, 6, 7, 9, 10, 11, 12, let's now try to memorize it by somatic motor, brachial motor, visceral motor, general sensory, special and visceral sensory. Then cerebellum, again, I don't think any of you will have problems in diagnosing a cerebellar stroke. We all know that cerebellar presentations, cerebellar signs, they are so peculiar that you will always pick up a cerebellar stroke. And the mnemonic is vanished, vertigo, ataxia, nystagmus, intention, tremors, slurred speech, hypotonia, exaggerated broad-based gait, and dysdiaphragm. Now, approach to stroke. We come back to the three case scenarios that we discussed earlier. So I'm going to ask you the question. You're going to tell me the answer with the points supporting this time. 60-year-old male, known hypertensive and diabetic, sudden onset weakness of right upper limb, had difficulty in gripping the brush in the morning. 5 minutes later, had focal conic movement of the right upper limb. He was aware throughout the episode. GCS was full and the patient was conscious oriented. Localize this for me and tell me the points favoring your localization. Cortical stroke. Okay. Can you tell me the points which are favoring a cortical stroke in this particular case? Very good, very good, very good. Focal monoplegia, seizures, seizures predominantly with preserved awareness and focal motor seizures. So, whenever you are having focal motor seizure, whenever you are having focal sensory seizures, they always favor a cortex limb. Differential limb involvement. This is a good term that you guys have learned today. A differential limb involvement or a monoparesis will present you like this. So things are easy. This is a simple cortical stroke. Now, an NCC or a tuberculoma can also present to you like this. So it's not just stroke always, but the localization is going to be perfect because tuberculoma and NCC history will be little different. Stroke, on the other hand, you will have a different history. But you will never miss about, see, neurology is easy when you know how the anatomy works. So if you can localize everything, if you can make a functional diagnosis and try to correlate with the anatomical diagnosis, things become little easy. How GCS is preserved. See, if the patient has monoparesis, if the patient has a small stroke, the GCS will be present in a cortical stroke. Will he be conscious in cortical stroke? Unless the stroke is large. And whenever you'll have a large cortical stroke, you will have a low GCS, patient will be drowsy, there will be a lot of edema in the brain, there will be lots of signs which will tell you that this is a large stroke. If it is a small cortical stroke, the GCS will be present. So this is how you have to differentiate. So patient comes to you with monoparesis, GCS preserved. Large stroke hemiplegia and also, I am going to the next slide. This is the first case. Now comes the second case. Now try to dissect this one. 60-year-old hypertensive diabetic, sudden onset weakness of right half of the body, power is 0/5 in both upper and lower limbs. Eyes are deviated to the left, and now in this case, GCS is low. What do you think? Cortical, subcortical, I see, I see, I see, large and hemiplegic, large stroke, subcortical stroke, edema, subcortical. Right. Now, two things. Number one, you will if you have to learn from this class. You should not make a diagnosis of internal capsule involvement in a patient who has a comatose state. See, internal capsule involvement means that the patient, even with a small stroke, will have dense hemiplegia. If it is a large stroke, it is not internal capsule infarct. Whenever there is a large stroke, it means that there is a cortex along with subcortical involvement. And when you have cortex along with subcortical involvement, you should not try to localize that stroke to be subcortical. I gave you good points to localize subcortical. So if you have a hemiparesis or a hemiplegia with preserved consciousness, no higher mental functional signs, no seizures, you will think about subcortical internal capsule involvement. If you have a patient with hemiparesis, hemiplegia, with drowsiness and comatose state in poor GCS, you have to think about a cortical involvement. Frontal eye fields are present there in the subcortex. I agree with you, but if it is just a small subcortical infarct, it will not present with comatose state or poor GCS. Right? So take it from me, you will make a diagnosis or a localization of subcortical structure only if you have hemiparesis, hemiplegia with preserved consciousness, no higher mental functional signs. Because you guys know cortex is present. Whereas if you have higher mental function signs, you have aphasia, patient is sitting, patient is saying, not able to speak, he has aphasia, he has Broca's aphasia, and probably some grip weakness. And he's literally sitting and looking at you and following what you are saying. That just means this cannot be subcortical. This cannot be internal capsule. This has to be either cortical or at the max corona radiata, but not deeper than. So yeah, this is a large cortical stroke. So when I say large cortical, I'm trying to tell you that cortex plus subcortex both are involved, but we don't call it as a subcortical stroke involving the cortex. We say it as a large cortical stroke. Third, 60-year-old sudden onset weakness involving left upper limb and lower limb. Power is 1 by 5 in both upper limb and lower limb. GCS E4 V5 M6 conscious. I see. Very good. Subcortical. Very good. So you can make a diagnosis of subcortex. Now let's take one more step ahead here. We have gone into details. Subcortex at what level? Corona radiata or internal capsule? Or thalamus? Internal capsule. Yes. Can. So here this is a case where you can safely say that probably internal capsule because there is a dense weakness and the GCS is preserved. Corona radiata, I would have said if the power is 3 by 5 or 4 minus by 5. Yeah, internal capsule because of power. Very good. So dense hemiplegia does not mean internal capsule. If there is a dense hemiplegia, you have to look for cortical signs to call it as. Now, because you might think that this is a theoretical class, this will, uh, you know, clinically it will make a lot of sense. A patient is has come to the emergency, left upper limb, lower limb, he is not moving, power is 1 by 5, patient is dull and drowsy. You will ring up an alarm, call up the neurosurgeon, call up the neurologist, and suspect a large stroke where you have to do a decompressive craniotomy or you have to give anti-edema measures and you have to be on your toes. Compared to a person who is not in window, who is 1 by 5 hours sitting comfortably talking to you, you need not ring up any neurosurgeon. You might need to just call up a neurologist or you can take care of the patient yourself. So this is a subcortical. Right. So by this we end today's class. I hope it was helpful. And this class was just to help you localize where exactly the stroke is. From the next part, we are going to talk about syndromes. Now you have the knowledge of arterial blood supply, anterior circulation, posterior circulation. You have a knowledge of cortex, subcortex, and all those things. So we can now safely enter the zone of arterial supply. and talk about the complicated syndrome. Hemiplegia with aphasia and facial nerve palsy localized. Dekho, if you have, I have read Harrison but never. Okay. So if you have hemiparesis, hemiplegia with aphasia, don't try to localize it to subcortex alone. Try to think that this is an involvement of corona radiata, which is having a mixed picture of both cortical as well as the subcortical features. Having said that, it is not a mandatory function. It is not mandatory that whatever these are general points. Monoparesis with speech impairment. See again, monoparesis and speech impairment. You have a cortical sign, you have a differential limb weakness. Why are you asking? You have to answer yourself. This is a cortical limb. Again, differential limb weakness in 2 points. Decerebrate posture. Okay, so decorticate and decerebrate posturing, they're going to learn in brainstem down. It's a difficult topic, it's a difficult localization, but to cut it short to you, red nucleus is your boundary. If the level of involvement is above the red nucleus, it is decorticate, and it is decerebrate if it is below the level of red nucleus. Decerebrate just means that it is more poorer prognosis. Decorticate is a little better prognosis than disabled, but it has got nothing to do with stroke. So, okay, Chirag, we'll end the session. We can take up questions later on.
Recording stopped.